All right, we're going to go ahead and keep on schedule and start with our next speaker, who will be Dr. Stephanie Randle. Dr. Randle is a pediatric neurologist and epileptologist at Seattle Children's Hospital. She is originally from Southern California, however, completed her medical school and pediatrics training in Chicago. She came to Seattle for her neurology and epilepsy training and has worked as faculty at Seattle Children's Hospital since 2016. Dr. Randle is the medical director of the Tuberous Sclerosis Complex Program and Epilepsy Surgery Program at Seattle Children's Hospital. She also serves as the vice chair of the Epilepsy Foundation's Professional Advisory Board. And I will also add that she volunteered this past summer on the medical team at our Camp Discovery. Please welcome Dr. Randle. You can close out also. There's things on the desktop.
Okay, thank you.
You should see it when you close out that.
Thanks, Kevin. Okay, great. Well, thanks everyone for coming today. I am honored to get to talk to you a little bit about epilepsy surgery and some of the innovations that we have in our care for patients who have drug-resistant epilepsy. Hopefully we'll have a few minutes for questions at the end, but I'm also fine if you want to interrupt. So yeah, here we go. So we're going to talk first about what drug-resistant epilepsy is, how we define it. There are other names that people use when we talk about it, and so you may yourself use other names. You may hear your doctors or providers use other names. We'll talk about who's a good candidate for epilepsy surgery, what that workup looks like at Seattle Children's, which I would say is somewhat interchangeable at other institutions as well. Most of us follow a similar pattern of how we work patients up, and then what options we have for epilepsy surgery. So in the right patient, epilepsy surgery can offer a cure, and that's something I think is really exciting to be able to say, and sometimes is novel to patients with epilepsy who have been treated for many years, maybe without having heard that surgery can be an option for cure. So when should we think about it? And really, I think we've had a really big shift in how we say, let's think about it early. Let's not wait till you've had epilepsy for 5-10 years. Let's not wait till you've failed multiple medicines, but let's really think about it from the beginning. Doesn't mean we're going to do it from the beginning, but just kind of getting that thought in our minds. We know that epilepsy surgery is underused, and it actually, with some of our newer devices, you may have met the DBS company outside in the back. One of our newer devices that we have, epilepsy surgery, whether it's brain surgery, resection, or a device, can be an option for almost any patient who has epilepsy, and should be something discussed with every patient who has drug-resistant epilepsy. We talk about if someone, if they've failed multiple medicines, that they can be drug-resistant, but we also think about if you've failed one medicine, but you have a lesion or an abnormality on your brain scan, that would be also consistent with drug-resistant epilepsy. So on the left-hand side, I always get my right and left confused on the projectors. On the left-hand side, you can see a bunch of different terms listed, and those are terms that people will use kind of interchangeably with the phrase drug-resistant epilepsy. The International League Against Epilepsy is the group that helps us come up with our names, and they really have stuck with the term DRE, but you'll hear many people use some of these other terms as well. And we know it's very common, and this is all comers with epilepsy, that in about a third of adults and about 25% of children, they may not respond to medicine. Sorry, this might be a little small for you in the back, but the way we came up with this, the definition for the term drug-resistant epilepsy of failing 2 medicines, is based off of some really good literature from actually many years ago, 25 years ago, looking at what happens if someone starts an anti-seizure medicine, how likely are they to become seizure-free, how likely are they to become seizure-free after subsequent medicines are added, and really after failing 2 medicines, the likelihood that the 3rd, the 4th, the 5th, really curing or stopping the seizures becomes lower. Doesn't mean we don't try, but certainly is a time for us to think, okay, is there something else that we can do? So again, here is just an easier way to see the data, but after failing 2 appropriately chosen medicines at therapeutic doses tried, the likelihood is about 4% that the 3rd medicine will make you seizure-free. And that's actually quite a low number in our world. And that's how some patients will, over years, maybe get stuck just trying medicine after medicine after medicine without thinking about other ways to treat their epilepsy. This is from that paper just showing you the data that after trying the first medicine, about half of people may respond to it. And then the numbers kind of by the stars, you can see in parentheses, get lower and lower the more medicines you try. And then down here, response to the 3rd drug and then subsequent drugs is about 4%. Of course, that was 25 years ago. We have many new medicines since then, but still the data isn't really supportive of a significant improvement with subsequent medicines tried. Again, that doesn't mean we don't try, but just time for us to think about what else could be an opportunity to help treat our loved ones with epilepsy. I mentioned if you have an abnormality on your brain scan, surgery may be a really good option for you. The likelihood in certain cases with certain types of brain scan abnormalities, the likelihood that patients will be seizure-free with medicine can be quite low. And that's what this picture graph is showing us over here on the right-hand side of the screen. The top part with the dots are patients with epilepsy without a structural brain lesion. So for all intents and purposes, a normal brain MRI. The one on the bottom, the line on the bottom, are those who have an abnormality on their MRI. And you can see how quickly this line drops, showing that patients with a lesion have a much more quick time to become intractable to medicine. So why do we think about surgery? If we take everyone with epilepsy, which is a huge spectrum, right? It's a very heterogeneous disorder. You can have it because you have a genetic condition. You can have it because you had an infection in your brain. You had a stroke. So if we take everybody under the sun, we know that seizure remission can be around 40% with a surgical intervention. Sometimes that may not be necessarily the whole goal with the surgery. It may be that we really just want to reduce the frequency of seizures or reduce the severity of seizures. And that's sometimes where we call it a palliative procedure, which we'll talk a little bit more about. We know that patients who have an abnormality on their brain scan, particularly if it's in the temporal lobe, that they will tend to have the best outcomes with epilepsy surgery. So about 60-70% seizure freedom. And then there are a subset of patients where we worry that maybe epilepsy surgery may not offer the cure that we're hoping for, but may be a good option to still try. And those are patients who may have their abnormality outside of the temporal lobe or have a normal MRI that, to me means we're just not seeing the abnormality right now in the MRI, or the abnormality is really close to an important area. And even though we'll do a surgery, it may be a really well-done surgery, but the surgeon has to stay away from the really important areas, limiting what can be resected. So why do we think about offering surgery? We know that the longer patients go with untreated epilepsy, the higher risk we have with lower IQ. And I take care of children. The majority of the patients I see are really actually quite young, infants to about, I see kids of all ages, but most of the kids are young, infants to about 10 years of age, and that's really the prime time for development, learning new skills, acquiring those really important basic skills in school. And so if we can get the seizures under better control, particularly in that young age group, we're really hopeful that we can combat some of these side effects of uncontrolled seizures. We know that with uncontrolled epilepsy, studies show that patients will have a higher time completing high school, holding down a steady job, living independently, maintaining important friendships as they age. And so all things that, we certainly want our patients to live full and happy lives. So if we can improve upon this, it's really important. We know that with uncontrolled epilepsy, the risk of SUDEP, which I think we'll hear a little bit more about after my talk, increases. And SUDEP is what we say is sudden unexplained death in epilepsy. As Lindsay Morgan might have touched upon that this morning as well. And really, we're worried each year someone goes untreated with epilepsy, the risk of passing away from complications of their epilepsy increases by 0.5%, but cumulative. So if I'm seeing a kid who is 1 year of age, we want that child to live a long, healthy, happy life, but if the risk of passing away from epilepsy increases by 0.5% per year, that's quite scary over a lifetime. And then certainly there are other complications related to epilepsy. I don't need to tell you all. You can injure yourself with a seizure. You can aspirate or choke on your own emesis or vomit or drooling. You can hurt yourself by a fire, in water, et cetera. And so all things we want to try and improve upon with better control of seizures. This is the surgical evaluation that we do at Seattle Children's. I think at University of Washington and Harborview is quite similar. And when I speak with my colleagues around the country, we tend to do a very similar process. But anyway, I like to start with this slide here. So the goal of surgery evaluation is to localize. Where is your seizure coming from? And so it's not good enough to say it's coming from the United States or the state of Washington, for example. We want to know even more specific to that. So, okay, great. We know it's in the state of Washington, it's in the city of Seattle. City of Seattle's huge, right? The brain is huge. There are so many different parts of the brain that can cause seizures. We really want to know more than, it's the left side of the brain, for example. Where on the left side of the brain? Okay, great. It's city of Seattle. It's in the neighborhood of Eastlake. Okay, so now we said, it's left side of the brain, but frontal lobe. Still, that's not enough. We want to know exactly where in the frontal lobe is it. We want to know exactly where in the city of Seattle, in the neighborhood of Eastlake, are you? And this is, I'd say, the precision, right? We say, in the neighborhood of Eastlake, in my house, right on the sofa. And so one of our surgeons always gave this example, and I thought it was really, really great. And so that's kind of how I'd like to think of how we do the surgical evaluation, is really pinpointing exactly where in the brain is it, the very most specific area, if we can. And in that we want to know exactly where are you sitting in your house, rather than knowing you're in the city of Seattle somewhere. Sometimes we're not able to do that, and that's where the decision comes into what kind of surgeries do we offer patients. So at our institution, our surgical evaluation kind of looks like this. We tend to see patients in our epilepsy clinic. We have now almost 11 epileptologists who see patients for these second opinion or consultations for epilepsy surgery. And if we think it's appropriate in the right time and we talk with families about it, then we'll order what we call the phase 1 evaluation. And I have listed here kind of what goes into that, and we'll break that down. Almost everybody will get this full evaluation. There are times where one test or another may not be necessary or may not add to what we already know, but for the majority, most patients will get a complete evaluation that you see listed here. The top part is our neuropsychologic evaluation, and that can be really helpful in understanding. I always say it's like fancy IQ testing, and so the neuropsychologists will do IQ testing, but they'll also dive in much deeper. So what are your strengths and weaknesses? Where are areas that we think are not functioning normally and maybe supportive of that part of the brain not working correctly? Or suggest, if you take it back to the analogy of what part of the house are you sitting in, the neuropsych evaluation may help us say, they're probably sitting on the couch, or they're probably in the living room. They may not say they're sitting on the right side of the couch, but they may help us get closer. The EEG is one of the first line tests that we do to really say, where are seizures coming from? And this is just a nice example of someone having a seizure. We tend to look at EEGs spanning the whole brain. And so in this example, the right side of the brain is on the top and the left side of the brain is on the bottom. And you can see here that the squiggles get a lot faster. And to us, that looks like a seizure. And the good news with this example is that the seizure's pretty easy to see where it started. And that's often you'll hear doctors say, we really want to know what the seizure looks like at the beginning. Do you have stiffening on one side? Yes, it may turn into whole body shaking, but at the very beginning, what first happened? Because that can kind of clue us into where is it coming from. So the EEG, like I mentioned, is one of the pieces of evaluation, and if it can tell us one part of the brain that we're worried about as the cause, that's great. The second second most important or really quite important part of the evaluation is an MRI of brain to look at the structure of the brain, Do you have a normal scan? Do you have an abnormal scan? If you have an abnormal scan, what is the abnormality? Here are a couple of examples of areas where the cells themselves just didn't develop normally. We call those dysplasias. Those are a very common cause of intractable or drug-resistant epilepsy, and can be a very good candidate. Patient who has a dysplasia could be a very good candidate to have surgery as a treatment for their epilepsy. A PET scan. PET scan is a type of imaging where we look at how the brain uses sugar. And so in this example, you can see quite nicely that on this side of the scan, there's more blue. On this side of the scan, there's more green and yellow. And it's pretty much as simple as that, right? Here, there's more blue. Here, there's more green, yellow, and orange. And so we're saying, okay, there's an asymmetry. One side of the brain is not as actively using sugar as the other side of the brain. And the side of the brain that we think is abnormal is the one that I've circled for us here. That's darker. And so the goal is, okay, does the EEG show that the abnormality is there? Does the MRI brain show that the abnormality is there? The PET scan, same thing. And neuropsych, is that supportive that this is an area that's not working normally? To help us understand what's an important part of the brain, or we call an eloquent part of the brain, we use a test called a functional MRI. In the past, we would do a test that was quite a bit more invasive called a WADA scan, or a WADA testing, and we don't tend to do that as much anymore. Actually, we don't really do that at all at our institution. Sometimes we will ask on the adult at Harborview and UW if they'll help us with it if we need it. But in functional MRI really can be a good opportunity to see where is someone's language and where is their motor functioning, as well as where's their memory housed, because we would like to stay obviously away from those areas, those really important areas, if we're thinking about a surgery. So I have a couple of pictures here of what an fMRI might look like if someone has one done. On the top part, we ask the patient to move their right hand, and we can see on the left side of the brain the nice orange and red areas that light up. And that is telling us where motor is being processed when someone has that function of the hand. So then we can extrapolate that and say, okay, this is an important area for motor functioning. If we remove this area, the person may be weak in that arm or leg or that side of their body, so we would want to stay away from that. We also use fMRI to look at language and someone who can cooperate. That can sometimes be a challenge with our kids, but we can work our way around that if we need to. And with an fMRI, what we'll do is we'll have a patient look at a picture and say what they see in the picture. And so there's a bit of a visual element to it, but also really what we're wanting to see is where is language processed in the brain. And in this schematic where the brain is moving, that's the right side of the brain, so we don't see the language processing there. But now here we can see the bright yellow and orange on the left side of the brain, telling us where someone's processing their language. In the still picture, you can kind of see, again, giving us boundaries on really important areas that we'd want to stay away from if we're thinking about surgery. The last thing we'll ask the fMRI to do is tell us where memory is most prominent. Some people have processing of memory on both sides of the brain, but most people will have one side that's a bit more dominant than the other, and in most people that's the left side of the brain. And again, just a nice picture. We ask the patient to think of something that triggers a memory for them, and you can see here where it really activates in what we call the left temporal lobe in this example. And so we can say, okay, yeah, the memory is a bit more importantly processed on that side of the brain. One of the newer technologies we've been using is called transcranial magnetic stimulation. This we use in conjunction with functional MRI to look at where motor is. So we really want to make sure, that we're pretty confident as we can be where motor functioning is. And so what the team will do is they take the fMRI. So you see the yellow-red part on the brain scan here. That's where we saw fMRI motor. And our team will stimulate movement by stimulating that part of the brain, and then they'll map exactly where is motor on the brain scan. So just giving us more redundancy in where important parts of the brain are. Okay, so now we've gone through our phase 1. We have all of our data. We present it to our whole group. And that's been, I think, a really important piece of an epilepsy surgery evaluation. It's never just one person who's making these big decisions. It's a team effort. So we have neurosurgery, neuropsychology, radiology, our nursing staff, and many others who can really help us understand how to put it all together and what may be the next best option for these patients. All right, so now we're going to look going the other way. So if someone has an abnormal MRI, so they have a lesion or a structural change, then we can think of a couple of options moving forward. So either we jump straight to a surgery. We say, yeah, everything lines up to the dog sitting in the very middle of the couch in Seattle, in Eastlake, in Washington, in the United States. And we may not need to go through any more testing, and we don't think it's close to anything important. So the surgeon may offer a way to either remove the tissue or laser ablate it, which we'll talk about in a minute. Sometimes we've done all that testing and we're still not as confident as can be, and so a patient may need to move on to what we call a phase 2 evaluation, and that often is what we call a stereo EEG, which I have some slides on in the next few. Sometimes we'll do a grid, and so we'll talk about the difference between the two. And that just helps us really sample the seizure from the brain itself. So the surgeon will implant the EEG into the brain, and we can really say, okay, yeah, it is exactly that part of the sofa and not the other part of the sofa. And so after we get that data, then we'll present the patient again to really make sure we're all on the same page before we decide on next steps. If the MRI doesn't really give us a good answer and not everything's lining up, or we thought it maybe was a focal seizure onset, but really it looks more generalized, then we may still do the phase 2 to really help answer those questions. We may say, you know what, no, we're pretty confident that it's not something that a resection will help with, or it's, we know it's right next to language, and this is a really well-developing 15-year-old. We don't want to take that risk. Then we may just move straight to what we call neuromodulation, which we have some slides on at the end. So the whole point of this is just to give you an understanding of how we think about patients with drug-resistant epilepsy and how we approach offering treatments apart from medicine to help potentially offer a cure and potentially offer an improvement in seizures. Okay, so I mentioned the phase 2. The phase 2 is either a stereo EEG or a subdural grid EEG, which some of you may have heard of before, some of you may have experienced before. But this is not a comprehensive list, but a pretty good list of why someone might undergo a phase 2, which I think I had mentioned some of that already. So we think it's focal, but we don't know exactly, or the MRI isn't really giving us the answer. Or we know it's focal, we know the MRI is giving us the answer, but it's really close to something important and we want to rule it out. Or we want to give a good boundary of where the important area is. Or we think the seizures, we're really pretty sure the seizures are from the right side or the right frontal lobe, but there's a little bit inside of us that's worried. Maybe it's the other side or maybe it's a bigger area. And so the stereo EEG can help us with that. And then, a couple of other good examples of why someone might undergo a stereo EEG. Multiple lesions. So in some conditions, patients will have multiple areas where the brain just didn't develop quite normally. And so we really want to prove, okay, it's this one in the more frontal than the one that's a bit more posterior right behind it. So some nice pictures. I always think pictures help understand what people are going through. And so in the very middle is a schematic MRI scan. And you can see each colored kind of little stick is the stereo EEG that the surgeon implants into the brain. And so it goes deep into the brain. That's what this picture is showing you here. So the top of the brain's up here, the inside of the brain is down here, and the surgeon will implant the electrode going into the brain. And so that will allow us to see, okay, if someone has a seizure, is it coming from this one or is it coming from this one, for example? And we can get that level of precision to really guide what might offer a good resection. When someone has a seizure, sometimes can look really obvious on the stereo EEG. So here's before the seizure, here is during the seizure, and right when the seizure starts, the EEG kind of gets really quiet. And so I always like this picture because I think most people, you don't have to be an EEG reader to see that there's a pretty obvious change right here in the very middle of the screen. And so when we see that, we're really happy. We're like, okay, great, we're really right over the area that we're worried about as the cause of seizure. We'll then go and take that data and put it back onto the brain and say, okay, this is what we're worried about. And then we'll say, how close is it to that motor area we found on the fMRI? And if it's, abutting it, so where the green line is here and the motor is here, then we'll do a bit more testing to say, okay, we'll stimulate, when someone has the EEG in, we'll stimulate it and we'll see if we can move their arm, for example, or move their face, for example. And if we can do that, how close is that to where the seizure began? We'll also do the same thing for language testing. We'll say, okay, we think the seizure is coming from somewhere close to where language is. We saw the seizure coming from this orange line here. So let's test the orange line and let's test the line in front of it, the electrode in front of it, to see, can we stop someone from talking, if we interrupt them with the stimulation while they have the EEG in. And so this is an example of one of our patients who we were doing language testing, and we went across this whole blue electrode, the 3 different ones, and stimulated all of that, and only in part of it, we got the patient to stop talking, stop saying what they're supposed to say. And so we can, with confidence, say, okay, that's a really important part of the brain. That's helping the patient express their needs and have expressive communication. So we really need to stay away from that area. Probably about 90% of patients, if they need a phase 2, will undergo a stereo, but maybe about 10% a subdural grid may be a better option. And that's usually if we really, really need to pinpoint where language is in relationship to where we think the seizures are. Stereo EEG is less invasive. It has requires less time in the hospital. And for many reasons, most institutions in the United States, and I would say probably around the world, have shifted to doing more stereo EEG than subdural. But it can be a very important test if needed. And so with the subdural EEG, the surgeon actually has to go in and remove the skull. They put the EEG onto the surface of the brain, and then we try and do the same thing, provoke seizures, see where language is. And this is just an example of a patient who underwent a subdural grid at our hospital. We cover a really big area of the brain with this map, but it's just the outer part, the top part of the brain, so not getting deep inside like the stereo. But we were able to see, okay, the seizures are coming from here, the language is coming from here, so we'll be able to guide the surgeon and say, we need to really, if you're going to do a resection, you need to stay away from this important area. So I've briefly touched upon the different options we have for surgery, but this is one of the ways I think about how we get to what we offer somebody. So if we start in the middle, drug-resistant epilepsy or medically refractory epilepsy, is it focal? Is it localized? Is it a single focus? Like we know exactly what's going on. Then most patients will be offered a resection or an ablation. But if we're not quite sure, there are a couple of areas we're worried about, or the MRI doesn't really give us the answer, then a phase 2 may be needed, or we may think about neuromodulation. And then if someone has generalized epilepsy, I haven't talked much about that today, but certainly a very common cause of epilepsy that can be quite debilitating and sometimes very hard to treat with medicine. Those patients tend not to do generalized by the nature of the word, right? It means kind of everywhere. And so we tend not to know of one area that's the cause of seizure. And so taking out part of the brain probably won't be the best treatment because it's hard to find just one area that's the problem. And so for those patients, they may jump straight to neuromodulation. And so just a couple of pictures of what resections may look like. Here are a couple of our different patients who, just this is to highlight that you can have resections from almost anywhere in the brain that we can prove is not an eloquent area. The surgeon may either go in and just remove a very small area. If there's a tumor, for example, they just may remove the tumor and not the area, all the way around it. It may be that we think it's a small part of the temporal lobe, but we know that probably other areas around it are important or are involved in the epilepsy network, and so they may do something a little bit larger, like more of a lobectomy or a temporal lobe resection or a full lobe resection. In some more extreme cases, we see patients where maybe part of the brain or half of the brain has overgrown. In some cases, we see young children who maybe had a stroke when they were born, and so half of the brain is really affected from that. And so those patients may be really good candidates to have what we call a hemispherectomy. So this is before surgery, this is after surgery, and the surgeon will go in and remove part of the brain on that affected side, but also disconnect it so that the right side of the brain isn't talking to the left side of the brain. And that can be a really good option for patients. These patients tend to have very hard to control seizures with medicine, but can respond quite nicely to surgery. At our institution, we do laser ablation, but I would say that it's less common than resection and less common than on the adult side. I tend to find that the adult epileptologists tend to do this a bit more for temporal lobe epilepsy. But here's a nice example of where this patient had, we call mesial temporal lobe epilepsy, and the surgeon went in. You can see the catheter for where they put to do the laser therapy, and then they burn the tissue around it, and then I think this is 6 months after the surgery. This is kind of immediately after the surgery. 6 months after, you can see that that area is filled in with fluid because the cells themselves have kind of died off after the surgery, which is the intention of that laser surgery procedure. There are a couple of types of epilepsy that respond very well to laser ablation, and so they're a bit more rare, but hypothalamic hamartoma is a type of epilepsy where patients can have overgrowth in the very middle of the brain called the hypothalamus. And as you can imagine, the very middle of the brain is a hard area to get to with a resection, with a surgery, right? You have to go through a lot of important areas to get there. And so laser therapy, again, can be quite beneficial and in curing the patient of their epilepsy without a big morbidity or injury. Some kids that we follow may have what we call drop seizures or atonic seizures, and those can be quite debilitating. You know, you fall right away. I once had heard someone explain it like those old kind of puppets where you press the button and then they just collapse. And so, of course, if you're just collapsing, you don't have time to brace yourself, and so most people have pretty serious injuries when they fall. And sometimes the treatment can be as quite effective by disconnecting the tissue that connects the two sides of the brain. We call that a corpus callosotomy. And more recently, we've been able to do that with laser therapy also, so making it a less invasive and better tolerated surgery for these patients. So in the last few minutes, I was just going to touch briefly upon neuromodulation. That's, I'd say, kind of the wave of the future for a lot of our patients with epilepsy. The vagus nerve stimulator has been around for many, many years, and it's been approved in children for many years, now down to the age of 4. But more recently, responsive neurostimulation and deep brain stimulation have become available and been used a bit more frequently, both on the adult and pediatric side. But when we tend to think of these devices, as we tend to just say, a device, I'll explain it kind of like a pacemaker of the heart. So the vagus nerve stimulator and the deep brain stimulator tend to pace the brain. So we set it to give stimulation at a certain frequency and a certain strength to try and prevent a seizure from happening down the road. The deep brain stimulator has a few new technologies that are coming out that you might have heard if you stopped by the DBS booth a little bit earlier. They have ways of now programming the device to look for when they think you're having a seizure so that you may get more stimulation if that time is coming. But the device, RNS, has really been the leader in we call responsive neurostimulation, or looking for when a seizure is starting and trying to interrupt that. So the 3 devices work a little bit differently, but for right now, most of us tend to think that they can work somewhat similar. They can be somewhat similarly effective. We're still waiting on some more research to see, in which cases are DBS or RNS more effective than VNS and vice versa. But I would say, just in the sake of time and the sake for this talk, we tend to think of these as really good options if resection may not be the right option for our patient. So just a couple of cool pictures. So the RNS, the surgeon will cut out a little portion of the skull, and they put the device into they kind of put it into the skull so it stays flush with the scalp. And we're able to implant 4 electrodes, of which 2 record. And we can look at, it's kind of like having a stereo EEG in your brain at all times, and we can look at, okay, is someone having a seizure right now, or is someone's brain really irritated right now, or are they looking okay right now? And we can teach the device to say, okay, this looks like a seizure, and when you see this, we want you to interrupt it. And by you, I mean the device. So this is what our epilepsy team will get this data. It's all online on the cloud, and we're able to review it and say, okay, if you start to see this pattern appear, then give stimulation to try and stop it from turning into a big seizure. That can take time. It can take a lot of practice. It can take a lot of experience. But really, over time, the device and the physician and the team really get better at identifying, okay, what's a seizure for this patient and what is not. In this slide, you can see both the VNS and the DBS for this patient. This is a young man who had a pretty large area of his brain had an abnormal growth and a malformation. And so a big resection wasn't a good option for him. And so we started with the vagus nerve stimulator, and that the surgeon will implant the device on the left side on the chest, and then they thread the catheter into the neck, and we will program it to say, okay, every 5 minutes, give a stimulation of this strength, for example. And over time, that wasn't enough for him. He still had frequent seizures. And so we're now saying, okay, after 1 or 2 years of trying a VNS, if that isn't providing the response we want, then let's think about doing a DBS or an RNS for that matter. And so the DBS is also, it goes into the brain like the RNS, but we put that into the thalamus or the deeper part of the brain. And that same thing, we program it to say, okay, every few minutes, give this interruptive stimulation. And for him, actually, he's done really quite well. We're really hopeful when someone is having a reduction in seizure frequency with these devices. And obviously, we're elated if seizures stop with these devices. And that's, we've been really lucky in some of our patients who've had both devices that it may work even better together than alone. So just in the last couple of minutes, I wanted to talk a little bit about risk and outcome, and then we'll have a few minutes for questions. So in terms of risk, things are not without their risks, as you all know. So with the stereo EEG, the surgeons will typically quote, with every electrode that they place, there's a risk of bleeding. We do our best to minimize that risk. We'll get a special MRI to look at the blood vessels to make sure that when they put the electrode in, they're not hitting a blood vessel. But that's one of the risks that we look for. It's very rare that someone has a significant complication with one of the phase 2s, either subdural EEG or grids, but certainly that is also something that's followed if there's any sort of death or significant injury. And then post-operatively, if we've done a resection, as I mentioned, we do our best to make sure we're not in an important area like language or motor. But sometimes motor's a pretty complicated process in our brain, and we have one area that we call primary motor. The areas around that we tend to call supplementary motor. And so sometimes after doing a surgery in the supplementary motor area, people may be weak, but that tends to get better over time. And so we often will have our rehab medicine colleagues weigh in if that's an issue. In some patients, the seizures begin in the back of the brain, we call the occipital lobe. That area is really important in processing vision, and a lot of patients that undergo a resection in that area may have a change in how they process vision, and that's something that we tend to look for before we would do a surgery and explain if that's a risk moving forward with the surgery. But I'd say in general, the risks of surgery are far much lower than the risks of having continued uncontrolled epilepsy. And so for those reasons, we all think if this is something that may be beneficial to one of our patients, it's worth pursuing. We know that 65 to 80% of patients with lesional epilepsy become seizure-free after surgery, and we were talking a little bit earlier. Sometimes patients can come off their medicine. It's not usually right away, but over time, usually we wait 6 to 12 months before we make a change. But after that, if patients are seizure-free, we really like to try and get them off of medicine if we can, or off of multiple medicines, maybe staying on one medicine. And up to 50% of children who undergo a resection, they can fully come off of their medications. And really, that's just with time and knowing how well someone's responded. We know that the first 6 months after having a surgery is the best predictor of how you'll do long term, and so we follow patients very closely, certainly those first 6 months, and then at frequent intervals after that. We know a surgery that, depending on where the surgery is happening, like what part of the brain, and what the pre-surgical neuropsychologic evaluation looked like, patients tend to have improvement in memory, language, cognition, school performance, and those are all things that we're looking at beforehand and after surgery and getting data to say, okay, this is one of the goals of the surgery, certainly seizure freedom, but also improvement in development down the road. We know that quality of life is higher when seizure control is better, and so if we can have a way to improve seizure frequency, either with a resection or a neuromodulation device, that quality of life goes up. We know that in children who undergo a temporal lobectomy, quality of life can normalize to healthy individuals after 3 years of seizure freedom, and so something that we're really hopeful that surgery, even though it can be a long, daunting process to undergo the workup and then the eventual procedure, can be worth it at the end. And so just a few summary points. Drug-resistant epilepsy is common. All patients with drug-resistant epilepsy should be considered or at least have epilepsy surgery discussed. Doesn't mean that you're going to go tomorrow to have that done, but at least knowing what your options are. It should be considered early, so we don't want to wait 5-10 years down the road, which is the reality. A lot of times it can take a long time for patients to know their options and for doctors to feel comfortable discussing those options. Sometimes epilepsy surgery can lead to a cure, and we will do our best to see if a surgical intervention will lead to a cure in each person's case. And if not, we have ways to help improve the frequency of seizures and the severity of seizures with neuromodulation devices. It's overall safe and can be quite effective. And overall, if we are having an improvement in seizure frequency, that we know that improves quality of life, cognitive and psychosocial abilities. And so with that, I'd like to take any questions that you have, and thank you for your attention. I think, Kevin, you have the microphone.
Hi, so, well, once again, thank you for your presentation. So a little bit about me is I went through, those brain surgeries. I had a stereo EEG when I was 15 years old, and then 3 months later I went through a laser ablation, and then I would say about 3 years later I had a left temporal lobectomy. And it was interesting to see so for kids at least, what is the age range for children, considering I got this done as a teenager? What do you consider, what's the age range for children during those studies? Was it 0 to 18 or? So
your question is, what is the age range that we'll do these studies for?
Yes.
Yeah, that's a really great question, and one that we're always kind of debating, what's a safe age. We'll do the initial workup in someone of any age, so 0. We follow patients till they're 21 at our hospital. But for the stereo EEG, sometimes the surgeons feel that the skull needs to be a certain thickness for it to be safe. And so right now we're saying sometime around 2 or 3 is the youngest that we feel safe doing the stereo EEG in. But we've done surgeries in babies without, if needed. And so certainly it can go down to quite a young age.
Yeah, because I find it quite interesting because I've had seizures since I was 10 months old, and I'm 21 now. And we didn't take really much initiative into my treatment until I was 15. And so it's always just interesting with that aspect. And then, yeah, because then I had a temporal lobectomy at, I believe, 19. And they both had the same side effects of it was interesting because I had speech delays afterwards. So after my temporal lobectomy, I couldn't talk for 5 days.
Oh, wow.
And then it just randomly came back.
Yeah.
And just, different side effects and different experiences like that. And especially after my laser ablation, speech had a huge impact on my thing. So I was just low sharing.
Yeah, thank you for sharing. I think, that your story is not an uncommon story, where someone's seizure started as a baby and it took 15 years to get to a surgery. And that's something that is we've had these surgeries for a long time, but now we're really trying to raise more awareness that we don't need to wait, that you need to fail 5 different medicines before we think about this. And then to your point where you mentioned you had the laser therapy and then resection down the road, we're finding that in the right patients, sometimes laser is enough, but sometimes it's not enough. And so that's always a discussion we're having. Is it worth it to try the laser first, or do we just go straight to a resection? And that's kind of Dr. Novotny and I could come up here and argue about that all day. So I think your story is one that other patients have been through, and thank you for sharing, and hopefully something where we're raising all this awareness that it may not be 15 years for the next person who has something similar to you, that they get that evaluation sooner.
Thank you.
Mm-hmm. There's another question over. Oh, perfect. Thank you.
Thank you for your presentation. I have a question. My daughter, a year and a half or so ago, had a VNS because a surgery per se the outcome would be unacceptable, is what they said. But even all the way along, and she's tried multiple medications that have failed, negative side effects without the benefits, and yet that's still the first go-to. Even with the VNS, they're like, well, we could try another medication. We are 8 or more into it, and she doesn't tolerate them.
Yeah.
So, and I know it's hard for you to maybe speak to it, but it seems like they're more than willing to medicate, and we've done keto, we've done the others, kind of guiding ourselves on that with doctors' supervision and RD, but I've often said she's failed at all of these. It's been negative. Why do we try this again? Is it just they feel that's the only thing in their toolkit left? Or, how do you approach that? Because they'll be like, well, you're not a neurologist, which I understand that. But I also know when you're at 8 or 9 medications and none of them have worked,
Right.
and say a VNS has been better, but it's still not controlling it, what other alternatives are there when surgery typically is not an option other than the VNS?
Yeah, that's an excellent question, and something that we've also been trying to shift our approach when we care for patients like your daughter. The VNS for a long time was the last stop as a surgery for a lot of patients, and now in the more recent, I'd say last 2 or 3 years, we've been much more excited about being able to offer either a second neuromodulation device if medicine isn't tolerated or working, or the diet isn't working. And so that's often where we'll start with our patients who have a VNS. It's been a couple of years and it's not doing what we wanted it to do, that we'll start to think about another neuromodulation device as an option. Sometimes, and I should have a slide that says, these aren't, you're not just allowed one or the other one. Sometimes you can have a surgery and a device, or one or more devices, for example. I've seen some patients where when they were young, they weren't a good surgical resection candidate, so they got a VNS. And then as they got older, we went back and we're like, wait a minute, let's rethink if someone's is a good candidate for a different type of surgery. So sometimes just starting that thought process again can be really helpful.
To qualify that too, she did have a stereo EEG done, and they were unable to pinpoint where it was, and they didn't know if they'd be able to pinpoint it if they did it again. so that she wasn't a candidate for the others, and she was 19 when she had it done. So, and I understand though, initially when she was younger, they were like, not a candidate for VNS, but all of a sudden she became a candidate for it as she got older. And I know things develop, but so for us, how many stereo EEGs do you do? You know, in order to
Yeah.
be able to pinpoint it, and they were unable to.
Yeah.
Because it was coming from more than one place.
Right. Yeah, and then you don't want to put someone through it again if it's not going to give you new information. And that's where having that thoughtful discussion of what would this test add if we did it? You know, what would a different stereo add? It may add something new, it may not. And so then what are your options? And, but yeah, that can be quite challenging in patients who've had a VNS for a few years, thinking what other options do we have? And we do have other options. And so sometimes it just you need to go back to the drawing board a little bit.
So based on your presentation with the VNS, RNS, DBS, and the surgeries you mentioned, is that kind of the top of the line, like that's all we have to offer at that point once medications and diet's not working, or are there additional things in the works that help with kids such as generalized seizures where some of these options aren't a good option for them?
Yeah, there's always things in the works. I think we're all really excited about precision medicine, which wasn't the focus of this talk by any means, but that's part of why our evaluation now is including genetic testing to see is there a single gene that's causing the epilepsy, and is there a gene therapy for that? We're still somewhat far away from that for a lot of our genetic epilepsies, but there's a lot of hope on the horizon that we'll have that answer someday for particularly the more common genetic epilepsies. That type of testing can also help us understand what medicines may be the best for a particular patient, not going as far as gene therapy. So we have new drugs on the market that have been really well studied in certain types of epilepsies that patients may respond better than others. But, I hate to say, that's it. But really, I think of the treatment of epilepsy in 3 ways: medicine, diet, and surgery. And so sometimes you've tried all 3 of those, and then it's like your question as well. It's just, can we rethink any one of those 3 pillars that may now be a good option for that person? We have a question over here with the lady with the red sweater.
Oh, sure. And can I throw in one too while we're waiting on that mic? Hi.
Oh, hi.
So I know that you primarily work with children. I was wondering about the statistics that you showed on things like risks of complications with surgery and successful outcomes. How much do those change dramatically over time? I have a friend in her late 30s who's going through a lot of these evaluations right now, and I'm just wondering, are there certain age periods where surgery tends to be more successful and have lower challenging outcomes?
We tend to think of if you can do surgery, the earlier the better, especially if you're worried about being close to an important area. So you may have heard the term plasticity. So like in children and babies, we tend to think of the brain's ability to reorganize. That tends to be less common as patients age. And so someone in their 30s, I think it's probably hard for their brain to all of a sudden have motor in a different area. So that can make surgery a little bit more challenging to some extent, depending on where the abnormality is. And then the cause. So if it's like a new small tumor, for example, those patients tend to have a better outcome than someone where the MRI is actually normal, I had mentioned. And then where in the brain is the seizure? If it's in the temporal lobe, patients tend to have a better outcome with surgery than if it's somewhere else. And part of that is when it's somewhere else, we worry, well, maybe it's a bit more, it may look like it's a small area on the scan, but it may be that it's a bit more involved in other areas. And in an adult, it's just not safe to take out a big area. Whereas in kids, it's not uncommon that we'll take out, like I showed the hemispherectomy, that's basically removing half the brain. In some cases, we will disconnect, 3 lobes on that one side. And that's a big thing to go through that I don't think the adults will routinely offer something like that.
Hi, thanks again for your talk. I wanted to ask, I know that VNS is offered for like 4 and up. I wanted to ask how routinely is that offered? And because at that kind of like toddler stage, there is, in that young, there is so much growth. How is that managed? Is that managed by routinely going in and kind of, I don't know if upgrading is the right word, or checking on it? Yeah, just the management around that.
Sure. I'm not a surgeon, I don't put them in, but what our surgeons will do is in a young kid, someone that's 4, as you're saying, they're going to grow. And so the wire that they attach to the device, the generator, is long. And so they'll coil it so that it can extend as the patient grows. With all of our neuromodulation devices, they have a battery. And so the batteries only last a certain amount of time. And so with the VNS, they will need to go in and replace the battery at some point. And usually that's about 5 to 7 years, depending on how aggressively you use the device. My hope is, I say this in clinic all the time, if we put a VNS in today, in 5 to 7 years, maybe they'll have a rechargeable battery by then. The deep brain stimulator does have a rechargeable battery. I hope that answers your question. But yeah, we will offer it down to 4 regularly.
Thank you.
I was going to ask about, on the abnormal lesion part, would you actually if there was a predominant abnormality, structural abnormality?
Sorry, will you?
Oh, yeah, sorry.
Thank
If there is a structural abnormality that's found, so like the large lesion, at that point, would you just skip phase 2? I was trying to figure out, that's the one I was following.
So sometimes we do skip a phase 2, and we love skipping a phase 2 if we can. And it's really, if we're pretty certain that abnormality is causing the seizures and it's not in an important area, we will routinely skip the phase 2.
And what is considered large? Because you were talking about the different sizes of the lesions. You're like a large lesion or a small? Is there a percentage you would say?
Really, I think it's in relationship to the fMRI. So if it's a big lesion, but it's far away from motor and it's on the right side of the brain, for example, which we think is the non-dominant or non-language side of the brain for most people, then we will, we may safely say, yeah, we can skip a phase 2. There's not an exact number of the size. Yeah. Sometimes a really big abnormality, there's no utility in doing a phase 2. The surgeon will just go in and do a big resection. Yeah.
And then I was going to ask if you could put back up the SEEG to the fMRI slide, if you wouldn't mind. Sure. That was a good one for me to take a picture to send back to his dad. Oh. I appreciate it.
Maybe this one? Maybe I can have Kevin send it to you afterwards. I don't. Mm-hmm. Great. Well, thank you everyone for your attention and your excellent questions.